Hey everyone, this is Karen O'Hara, Director of Marketing and Communications with WorkCare. Thank you for joining us for week 12 of our briefing on preventing and managing COVID-19 in the workplace. We appreciate your continued participation. For those of you who are joining us for the first time, we welcome you. The session is being recorded and we will post the recording on our YouTube channel within the next 24 hours. During the discussion, Alexis will post the website so you can access that, and you'll be able to find answers to any questions that are asked during the session on our website also tomorrow. Please submit your questions while Dr. Harris is presenting using the Q&A function on Zoom. And now let me introduce Dr. Harris, with whom you're all familiar at this point if you've been joining us every week. Dr. Harris is an MD, MBA, MPH. He's board certified occupational medicine physician, and he's WorkCare's Chief Innovation Officer, Vice President of On-Site Clinical Operations, and an Associate Medical Director. He's our lead clinician for our COVID-19 response. Also, I just wanted to mention that we have a special webinar coming up next week on June 9th on mental health, and Alexis will post the Zoom registration link to that during the session. And that's going to be at 10 a.m. Pacific and 1 Eastern, featuring Associate Medical Director Brittany Bussey. Dr. Bussey presented a previous mental health webinar about 6 weeks ago, and this is a follow-up to that. So we hope you'll be able to join us for that, as well as next week's briefing with Dr. Harris. Okay, I'll turn it over to him. Thank you.
Excellent. Thank you, Karen, and thanks everyone for joining us once again here. And we have a wonderful presentation in terms of framing today and reframing how you think about your strategy for managing COVID-19. So we'll jump into it. If you have rejoined us today, we first thank you, and you'll be familiar with our format here, going first clinical update, then to the microbiology or pathology of SARS-CoV-2. Finally, we'll conclude with the epidemiology, prevention, and then workforce strategies for how we deal with COVID-19. So the update for clinical presentation, nothing new on the presentation of actual symptoms, but one of the emerging research topics around COVID-19 is how the illness is spreading, and in particular, super spreaders. Is a terminology that's being used more popularly now. Studies are leading to the conclusion that a vast majority of cases may have a central person that's spreading the particular illness. And when we talk about the clinical presentation, the research is still ongoing as to whether or not there's any underlying genetic or physiologic makeup that produces these super spreaders. And so we'll start there on the pathology piece of it, because it's the research that's emerging showing the presence of these super spreaders that is indicating it may not be necessarily the individual themselves that's causing the phenomenon of super spreading. This particular study looks at the makeup of a super spreader event, if you would, and it looks at that from the perspective of genetic tracing of SARS-CoV-2. We presented this tracing body of work a couple sessions ago and looked at the spread of the illness from Wuhan, China, throughout the both the Asian countries as well as the US and throughout the world, in fact. And this study looks at that and tries to answer the question about super spreaders. The next study looks at the statistical analysis of spreading SARS-CoV-2. And finally, the third representation of research looks at the phenomenon from the perspective of individual. And all three of them conclude the same, that super spreaders and the super spreading events may have contributed in terms of spread of COVID-19, 10% of the cases that include super spreaders may have caused or led to 80% of new infections throughout the world, not just the US, but throughout the world. And the body of work coming from the London School of Hygiene and Tropical Medicine, Tel Aviv University, and Institute for Disease Modeling. So this research will be ongoing, obviously, and we'll pay attention to the findings because they'll be relevant for how we deal with COVID-19 moving forward. Not just throughout the summer, but throughout the fall, if we do see a recrudescence of illness, and obviously how to prevent spread. So let's hop into the epidemiology update here briefly. If we look at the US in terms of growth of cases, 1.6 million cases as of last week, 98,000 deaths, up to 1.8 million cases now with well over 100,000 deaths. So we are continuing to see an increase, obviously, in terms of the impact from COVID-19. If we zero in specifically on number of daily new cases, we see from last week, we were on a slight decline, obviously, with the number of new cases. Positive news. If we look at today, the decline is still there, but we see a small increase in that daily newly confirmed cases in the US specifically. And as we look at then deaths from a daily basis, the trend last week was clearly trending downward. This week, unfortunately, we're seeing an uptick as well in terms of new deaths from COVID-19. Again, looking at specifically the United States week over week. Testing, how are we doing on testing in the US? Last week, continue to see an increased trend for number of tests per 1,000 individuals in the US. We continue to see that trend this week in terms of increasing the number of tests gradually per 1,000. If we look at daily new confirmed tests of COVID-19, then we can see last week we were on a slight decline, a little over 1.3, 1.7, 1.1, declining there, but this week bumped up. So it's good to see that, you know, we have the overall trend of number of tests per 1,000 on a daily basis improving. So last week we looked at a statistic from the US perspective of number of states that had relaxed minor, moderate, or major restrictions for social distancing. And we saw that Wisconsin, Utah, and Texas, and Alaska all had no particular restrictions yet in place. And if we look at the trend as of this week, we see that only Alaska remains in that none category and that there are restrictions in all states. Now, to that fact as well, all states have at this point relaxed in some way, shape, or form their restrictions. So this is a good sign that most states are conscious to the level of disease, obviously, in their state, but also that states are reopening gradually. So we're not seeing across the board states relaxing completely the social distancing that has helped us bend the curve thus far. If we look then and drill down on specific states and some trends that we want to continue to look at specifically, we want to understand better the association of the stay-at-home orders and the duration thereof in association with trends for increasing or decreasing cases of COVID-19. And there's some good data that has been summarized for us in this case by National Geographic, looking at specific states and the statistics thereof. Arizona showing an increase. All these states in the top 10, these 5 of the top 10 are showing increases in number of cases after the relaxing of social distancing in that particular state. Now, it's not suggesting that there's maximum cases being reported as a result of relaxing these restrictions. However, we are seeing an upward trend in these particular states. A few states also have experienced the relaxing of social distancing and had a decrease of cases and continuing. Unfortunately, though, no state has met the requirements that the federal government has put out in regards to how to open your state safely and restart the economy. Specifically, we're talking about the requirement to have a downward trajectory of cases in your state for a 14-day period. The other alternative is to have a downward trajectory of number of cases as it relates to the testing for a 14-day period. Unfortunately, again, none of the states have met this criteria, and we just saw that at this point, all states have taken steps towards reopening. So we'll continue to watch and examine to see if recommendations from the federal perspective changes regarding reopening, or how states respond to recommendations from the local and state health departments. So zeroing then on now reshaping how we think about the COVID-19 response for employers. That's going to be the main focus of today beyond the epi and the clinical presentation we've already talked about so far. We are going to present the aspects of what you've seen before, but we're going to present it in a new way in terms of thinking about the workplace new normal. Okay, so we know COVID is going to be around for the rest of this year. We know that COVID won't have a vaccine likely until next year. So the workforce and the employers will be undergoing some type of process for COVID prevention in the workplace. And when we describe prevention, we want to reframe it in the classic perspective of prevention. And we call this the worker health continuum, starting with primary prevention, secondary prevention, and tertiary prevention. They're in reverse order here to denote where we normally focus our efforts in the clinical community, which is on tertiary prevention. Classically, if we're talking about tertiary prevention, it means that we're intervening after you've become ill to prevent some type of permanent disability, right? That's tertiary prevention. If we're talking secondary prevention, we're speaking to those activities that help intervene after someone has either early symptoms of an illness or injury, and preventing that injury or illness from developing to its fullest, that leads to an actual disease state that prevents work in the workplace. And then if we talk about primary prevention, it's generating leading indicators. Let's say for an injury, musculoskeletal injury, a leading indicator would be the overexertion measurement of demand of work that may lead to a shoulder injury or back injury. So when we talk about the continuum of prevention, primary, secondary, and tertiary is the frame in which we normally speak to the workplace environment. So, and when we talk about shaping that for workforce strategies with regard specifically to COVID prevention, we want to also talk about it in the same light. Briefly, let me actually go back here just one slide. So you saw the slide of classic presentation. This is the slide that we want to reframe our thoughts around COVID management in the workplace. So primary prevention, we'll start with tertiary prevention. Tertiary prevention then is what we are talking about, what we've displayed so far in terms of workplace response when somebody's ill from COVID-19, right? And that's a process by which we want to be able to monitor the individual worker or workforce entirely, help with their absenteeism due to illness, and then obviously help with the return to work process. The secondary prevention piece then is identifying early symptoms of COVID-19 and ensuring that we have a process in place for getting that worker safely home and quarantined so that they're not infecting other individuals in the workplace. Again, that's secondary prevention because we know that somebody is potentially ill and we need to prevent an event that leads to tertiary spread of the illness. And then primary prevention, in this case, as it relates specifically to COVID-19, is how do we monitor the workforce from a health and wellness perspective, and how do we increase the opportunity to prevent transmission to begin with, right? And there's a couple things that we can put in place, best practices to help with that primary preventative approach. So we'll show this briefly because you are familiar, hopefully if you're rejoining us again, with the steps that we've talked about over the last several weeks. Step one being putting in place the daily screening process for not just IR thermography, but for risk stratification, right? And when we talk about primary prevention, certainly we're looking at those individuals that are well and trying to keep them well. Secondary prevention being, again, those who show symptoms, not necessarily diagnosed yet with COVID-19, but showing symptoms of infectiousness, and then having a process for getting them home safely. So when we talk about then what that looks like in practice, it really is a methodology in the daily screen to capture the well-being of the workforce, right? And we can see holistically, how is the workforce doing with regard to any symptoms whatsoever. And in practice, what we're seeing with the employers that we help through this process, well over almost close to 1 million screens that we've done now, we see 98% of the workforce do not have any symptoms whatsoever, right? And 2% of the workforce on a day-to-day, week-by-week basis are presenting with some type of presentation clinically that may be infectious in nature, right? Fever, cough, chills, etc. And then when we talk about stratifying, so that's the primary prevention piece and aspect to how we can look at the workforce and from a wellness standpoint. And then we can use those metrics, obviously, to help increase those numbers, right? Getting 2% down to 1% and maybe 0.5% in terms of what they're experiencing in the workplace. Secondary prevention being now, once somebody is identified as having a risk factor, how do we quickly put them in a category, risk stratification category of high, medium, or low risk for COVID-19? That's our secondary prevention approach, right? Because we're going to have that individual no longer at the workplace, and the process is in place to allow them to quarantine home safely and prevent transmission, secondary transmission of COVID in the workplace, right? And when we talk about then an approach to help with primary leading indicators, it really is understanding the local lay of the land as it pertains to incidence and prevalence of COVID-19. And we're continuing to build and provide tools to help our employers quickly ascertain what the level of risk is to their workforce as a result of community spread of COVID-19. And this is going to be important in terms of primary prevention moving forward, because we are anticipating in the clinical community that cases, although they may drop in the summertime, right, we may see very likely a recrudescence of illness in the fall. And so paying attention to that level of increase potentially is going to be important to protecting our workforce, and it's going to be geographic based and incident prevalence and incidence based. And then as we talk about the surveillance program, that also falls in both the primary and secondary preventative strategy, looking at the workforce from a geographic standpoint, the same. And then we won't mention the testing piece of it during this presentation. We'll come back to that at a future date and time to help show how the testing relates to articulating these type of leading indicators for the workforce. But we really want to focus in on now the tertiary prevention, right? What does that look like, and how do we really help build a program that's holistic in its approach to return to work, right? Because there are a number of solutions out there now that are developed around screening the workforce and providing some type of means to identify those who fall ill and hopefully get them home quarantined safely. But we're not seeing a plethora of options for the employer to do a wide-scaled approach to return to work, right? Monitoring workers in a robust return to work program that's supported obviously by clinical experts in the field. And so that's what we really want to emphasize when we talk about tertiary prevention, making sure your organization has a plan for a potential recrudescence of illness. And if unfortunately COVID-19 follows what happened back in 1918 with Spanish flu, the fall impact from illness of the Spanish flu was significantly more than the spring impact from Spanish flu. And that is certainly what we talked about last week with the university, one of the university literatures speaking to a scenario in which disease will be greater in the fall than it is right now and what we've seen over the last couple of weeks. So having a robust return to work program is going to ensure that you're able to manage your workforce effectively and not leave it to the circumstance that we're seeing and that we've seen, where the primary care physicians in a local community are the bottleneck to a return to work process, right? If we leave it to community availability of physicians, we know that we're understaffed there. And we showed those statistics, about maybe a month and a half ago, in terms of how the US fares against some of our other partners across the pond, Italy and Spain, that have a greater density of providers per capita. And so we have to make sure that our employers have a scalable solution in place that allows you to quickly identify the scenarios as we depict here. An employee is positive for COVID. What happens if they're exposed to a positive case of a household member? What happens if they're exposed to a if they're a healthcare worker and they're exposed? Or perhaps they're exposed in the community, right? So each of these scenarios need to have a defined plan and a defined return to work process so that you can quickly manage your workforce and prevent some of the shutdown that we've seen, some of the tertiary, secondary and tertiary spread of illness, right? So that's where we want to leave things today. We'll continue to expound on these concepts now that we're reshaping our understanding of how employers manage COVID into a frame that we're familiar with, right? A frame that talks about primary, secondary, and tertiary prevention. And then next week also, we're going to talk about a four-letter word. And it's an acronym, but oftentimes it's seen in the same light as other four-letter words. And we want to help ease anxiety around that. And that's OSHA, right? Back in May, mid-May, I believe May 14th, OSHA said employers are now responsible for understanding the causal nature of a COVID infection in your workplace, and you're responsible for documenting that causality so that you can place appropriately those events into your OSHA 300 log, meaning it's a recordable event now. And so that's a huge burden. That's a huge burden because it's complex to make that causal association. It's complex for us in the clinical community, let alone for our partners as large employers, small employers, to have the understanding to the depth that they can accurately make that assessment. So we want to talk about strategies that are going to be there and tools that are going to be there to help you during this new age of OSHA regulatory compliance with COVID-19 as we move forward. So I'll stop there. I'll present again, our strategy that we've launched over the last couple of weeks here, COVID Clear Zone, falling into the secondary preventative category as well as the primary preventative category. And we'll leave it for questions right now. Thank you so much.
Thank you, Dr. Harris. We've gotten some interesting questions and a couple of scenarios for you to address this week. I did want to mention in response to one inquiry we got that regarding California specifically, which requires a written response plan, that we are going to be launching a course for California employers within a day or so. We're just getting ready to put it up on our website at a very low cost. It's only like $5 to take the course. So those of you who are in California or have employees in California will want to check that out, and we'll make sure you hear about that. We don't have a link to it yet. But let's just jump right into the questions. Should an employer require an employee to self-quarantine at home for 14 days after traveling out of state for vacation currently? For example, an employee who lives and works in Illinois and wants to travel to Florida or Tennessee.
Sure. So that evaluation falls very closely into the same evaluation that we do, that we've done early on in COVID exposure, right? Did you travel somewhere that may be high risk for COVID-19? And what we have employers doing in regards to relying on us in the clinical community is to walk through that same evaluation. And it's going to be a case-by-case scenario of understanding the potential exposures and that individual's absolute risk. And so the quick answer is no, you shouldn't just require it merely based on the fact that they've traveled. But it should be a consideration that has a process for evaluating their individual risk, and then a determination is made. And we can talk more afterwards, offline or after this, on how we've helped employers approach that scenario and what they're doing to address their traveling workforce, that now that we're in phase 2 and phase 3 of the reopening of the workplace, we're seeing more and more travel.
Okay, next question. Should I remove employees from the workplace if they are presenting any of the COVID symptoms, whether it's a sore throat or a headache?
No, again, much like the previous question we just addressed, it's an individual determination. It is a complex one, so to speak, in that if you have a across-the-board process that just says any symptoms whatsoever means you're home, you're going to have a mess on your hands, as we saw early on with managing COVID, in terms of the workforce not being present enough to actually effectuate the business concerns. So with that being said, we found the best approach has been a comprehensive one, looking at the multifactorial assessment of an individual's risk of actually having COVID, as well as other infectious disease, meaning that a sore throat could be associated with seasonal allergies, right? Or a chronic cough could represent itself in a way that does not necessitate an individual being home quarantined. So partnership is necessary with your clinical support, and that's how we've been able to get a good response in regards to managing workforce presentations clinically.
I think it's interesting how this has changed the whole way we think about our own symptoms. Like you get a little tickle in your throat, and now it's not just maybe a little tickle in your throat, and it raises a lot of anxiety. So I think it's interesting how things are transpiring. This is a scenario that I'm going to read to you regarding a walk-in clinic. The question is, why are walk-in clinics giving a patient a note to stay home until test results are received if they don't have any symptoms? In this example, the person or the patient is a contact of a contact. The patient's wife has 2 coworkers who were diagnosed positive. The patient and the wife neither have symptoms, but went to get tested and now have a note that they are off work until the results come in. This creates the patient's employers now needing to provide the patient with a COVID leave paperwork and pay.
So I cannot speak, as we don't run at WorkCare these type of walk-in clinics. So I can't speak to the specifics of that scenario anecdotally. However, I can speak to what we have always seen as occupational health professionals, that those who aren't learned in our specialty of taking care of the workforce have always had a predilection to take individuals off work, whether that be for a sprained ankle or for a sliver that causes a minor cellulitic response in a finger, right? And so we are seeing very likely that continue into COVID-19 response clinically from those clinicians who aren't well versed as to whether someone who is asymptomatic should be at work, someone who has a cough, maybe due to a chronic illness, should be at work, and across the board, they're just removing people from work because it's the easy thing to do with the lack or gap in clinical knowledge.
I guess that falls into the category of having an abundance of caution and lack of familiarity, like you said.
Well, no,
next question.
I think it's even beyond an abundance of caution. I think it's it tiptoes into bad practice, right? Not best practices to properly manage the workforce for our employers. So in short, lean on your occupational health clinicians because they have the expertise to make those determinations better. Good
point. Okay, this one's about Germany. Are you familiar with Germany's protocol for treating patients with ozone instead of intubating? What is your opinion on this treatment? Their death rate was significantly less than ours.
I am not familiar with the ozone treatment for COVID-19 specifically. So I would love to learn more about it, and I will shortly after this presentation. Yet and still, though, there hasn't been any third-party or peer-reviewed ozone treatment in the US that I've seen that would move us in that direction, but would love to give an update on a future webinar here in terms of my research on ozone treatment in Germany.
That'll be interesting. Look forward to that. So if someone travels to the US from the UK for business, is there a period they should be quarantined in a hotel? Doesn't say whether they would have symptoms or not. We're presuming there's no reason to suspect they're contagious.
Yes, so much like the initial question that we answered here, it's a case-by-case scenario. There should not be, we believe there should not be a policy that quarantines anyone who travels carte blanche without consideration of the specifics.
If an employee gets a confirmed case of COVID after work-related travel, would that be something that you put on your OSHA log?
Potentially. So yeah, the OSHA has specifically stated that travel as a result of, or disease as a result of travel could be a recordable event for COVID-19. However, there are exceptions to that depending on where the individual resides during their travel. So it is more of a specific determination for case by case.
This one's right up your alley, Dr. Harris, because you're based in Chicago. The questioner says, I thought the governor of Illinois stated that we were the only state to meet the federal criteria for reopening. But then she says, oh, but it could have been Lori Lightfoot, the mayor. Are you familiar with that?
I am familiar with that statement. I'm still trying to substantiate it from other sources of data. Not saying it's incorrect. I'm just saying for what I've seen, I'm still on the research side to truly understand where that statement has arisen in terms of the data that supports it.
The next question is, are you seeing long-term effects or permanent damage resulting from COVID in survivors or people who had confirmed cases?
So if I can restate the question to make sure I understand it correctly, are we seeing any permanent disability or permanent sequelae as a result of COVID-19 infections?
Correct.
Got it. So yes, I mean, those individuals who have severe illness, who have been hospitalized, can have sequelae such as kidney failure, can have poor outcomes, certainly with respiratory failure, etc. So yes, there are some permanent impacts to an individual's overall health and wellness that we're seeing as a result of COVID-19. Now, is it solely because of COVID-19? Perhaps not, right? It's always, it's typically associated with secondary events, whether it's a infectious bacterial infection that occurs nosocomially in the hospital. There are a number of events that can occur that compound an individual's experience clinically from a COVID-19 infection.
So to follow up on that, say you're a super spreader, do you think there's any correlation between a super spreader's recovery or potential long-term effects because they were a super spreader from the start or not?
Yeah, so what we're seeing now in the literature is that the terminology super spreader may be a bit misleading in that, again, there's nothing conclusive to suggest that these individuals have a physiologic or individual factor to how they spread or why they spread broadly, but it may be more closely associated with an event, a super spreading event. And so that's where it looks like the research is mostly focused in on are what are those particular events that can lead to a super spreading person or individual that may be positive in that population for that event, such as what we presented, I believe it was one or two presentations ago with the Sentinel event at a church, and 9 out of 93 or 92 persons who attended that one event, over 30 of them were positive for COVID due to two individuals, the pastor and another individual.
Yeah, that was a good example. Okay, we have a couple questions left and then we're out of time, and we'll see everyone again next week. You've answered this one before, but it almost gets asked every single week, so I think we should answer it again. Are employers legally allowed to require COVID-19 testing prior to returning employees to work or as part of a pre-employment screen?
While I'm not giving legal advice, yes, EEO, as we understand it, EEOC, ADA have all supported and in some cases required employers, to test their employees before they can return employees to work. And we've been a part of that testing in Texas, in Florida, in Massachusetts. And so we know that is the current state. As to whether or not that will change as we move forward and experience different levels of illness in the communities, that's yet to be seen.
Okay, my kitty is here. Some of you might hear her meowing. Let's see, I think we had one more. Robert has asked this before, but I don't think we ever answered it except in the written version. Why are the percent of infected people in China, India, and the Soviet Union who have much higher populations have lower rates of illness than we do in the United States? Are their techniques that much better in containing and eliminating, or is it a case of actual numbers maybe not being reported as true or reliable? He also notes that he sees Australia has dropped off as well. What have they done differently, and what can we learn from them?
Sure. So if we look at some of the statistics as to number of cases versus tests conducted, we'll see that, particularly in India, as the slide is showing, being one of the locations questioned in this particular case, has drastically less per capita number of tests performed, which could lead to underreporting, not from any poor actors in terms of hiding cases, but more so that just the number of positive cases has been drastically underestimated due to the limitation of testing per capita. And so it most likely is associated with that versus a true huge gap in how different geographics and municipalities have addressed the response to COVID-19. Not saying that some have done better than others, right? We certainly know that's true, and we have seen best practices in place that has helped limit spread in different countries. However, for those locations that were mentioned in this question, it could be very likely associated with an underreporting due to lack of testing.
Okay, we have room for one or two more questions, and then we need to conclude to keep within our 40-minute window. Is the U.S. considered a level 3 health notice like other international countries? Does that make the U.S. travel restricted?
Yes, basically every major country has been at that level 3 for some time. When that is lifted in regards to the emergency declaration by the federal government, I'm not certain of at this point.
This is about the immunity test. Is there any reason to get an immunity test if you've been well quarantined without much contact and not sick? Or is this a waste of time and should instead be reserved for after you've had symptoms?
Say that, repeat that question for me, sorry, one more time, just to make sure I heard it correctly.
Is there any reason to get an immunity test if you've been well quarantined without much contact and not sick? Or is this a waste of time and you should just get a test if you've had symptoms?
So yes, the paradigm is that if you're healthy and well, and you don't have any risk factors regarding contact or exposure, it's mainly the question of who should get tested, right? And so the approach has been so far that no, you shouldn't test those who are well unless you're in a specific scenario of needing to return to work and establish a baseline for the worker population in regards to their exposure or not to COVID-19. So if you are not in that scenario, you've been quarantined and in a state of wellness, then not just for an antibody test, but for any molecular test or antigen test would be unwarranted potentially because the results wouldn't change your scenario or allow you to actually make a decision after that test. And in medicine, the classic approach to diagnostic tests are don't perform the test if it won't change the outcome. And certainly that would be the case with this scenario.
Seems like very sound reasoning. One last question, Dr. Harris. Do you foresee people who have survived COVID-19 given some sort of travel-free card, meaning they won't be hampered since they aren't liable to get the disease again or contagious to others?
Wow, that's less of a clinical question and more of a policy question, and one that I am woefully not credentialed to answer. Could it be? Absolutely. Will it be? Who knows? From a absolute immunity standpoint, from an immunologic response, we still don't know how long COVID-19 or SARS-CoV-2 immunity will last, but obviously these studies will continually be ongoing to try to answer that question more fully.
Okay, well, that wraps up our session for today. We look forward to having you all back again next week. And another reminder to join us on Tuesday also for more on the mental health aspects of return to work and how you can best help your employees manage some of their physical and emotional symptoms as they come out of sheltering in place and back to work. Thanks again, Dr. Harris. It's always great joining you on our weekly call. I'll hand it back over to you. Thanks, everybody. Take care.
Thank you, and stay safe.